This is Jay Callahan again. This is another one of our video mini lectures, and today we're going to talk about emergency intervention. So far we've been talking about crisis and crisis intervention, and now we turn to the other major topic for this class, mental health emergencies and the emergency intervention. Mental health emergencies, as we have been talking about, are immediate situations that involve the potential for harm or danger to someone. And of course, the most common mental health emergencies that we as social workers have to deal with are potential suicide and potential violence. I'm going to focus my comments about suicide, but these same considerations apply to violence as well. So the emergency intervention, as you can see on the slide, is an immediate one-session interview that has three major parts to it. So this comes about, as we've talked about before, whenever you have any reason to believe that a client might be potentially suicidal or potentially violent, then an emergency intervention is needed at that time. And the bottom line here is, what's the risk that this individual is going to try to kill him or herself or try to harm someone else in the next few hours or the next few days. We're talking about short-term issues here. We're not worried about whether they're going to try to kill themselves a year from now, but it's the next few hours or the next few days. So the emergency intervention has three major parts to it. The first part is an assessment or evaluation. I use those terms interchangeably. And first, there's a general assessment, which is what you do with anybody. Who is this client? What are their demographic characteristics? Family issues, job or career, what's going on in their life right now, and then essentially or especially what's going on in their life right now that has led to this crisis, or at least to this emergency. Remember that most mental health emergencies take place in the context of a crisis. Sometimes there are exceptions to that. People can become suicidal or violent when they're not in a crisis, but those are less common. So another part of the general assessment would be the current situation, the current crisis, the current stressful event that's happened. Then the second part of the assessment is probably the central core of the emergency intervention, and that's the risk assessment. The risk assessment is the specific answer to that question. How likely is it that this person will try to hurt themselves or hurt somebody else in the next few hours or the next few days? To do that, we look at risk and protective factors. And we'll be spending a lot of time on that. Risk factors, on the one hand, are factors that would lead the person to be more likely to try to harm themselves or someone else in the next few hours or the next few days. Protective factors are the opposite, things that would make them less likely to do so. So obviously risk and protective factors are the opposites of each other. Some are phrased in one way or another, but they're typically the opposites of each other. And you can think about it as kind of a balance scale, that there's a balance scale with risk factors on the one hand, protective factors on the other hand, and you have to weigh it out. It's a clinical judgment. You have to weigh it out back and forth in the context of what you know about that individual person at this point in their life. The other thing I've mentioned here on the slide is the case approach. And we'll be talking a little bit more about this later, but the case approach comes from Sean Shea, who is the author of the book that we're going to be reading about suicide risk assessment. And in his book, he talks about the case approach. It's really a way to organize material for someone who has a lengthy or complex history of suicide. And I believe it stands for the something assessment of suicide experiences. Well, we'll come to it in the book and get that straightened out. Then the second part of the emergency intervention is in-session treatment. So you may recall in the article we read earlier in the semester about family crisis intervention in the ER, they pointed out that in the typical medical surgical emergency room, a diagnosis is made and treatment is offered right at the time before the disposition or the plan. Where do you send them next? But the authors in that article pointed out so often in a psychiatric emergency service the focus tends to be simply on diagnosis and disposition. What's the diagnosis and where do we send them? Inpatient, outpatient, partial, whatever it might be. And they argued in that article, and I would certainly agree with them, that we should also offer treatment in the emergency room or in an emergency intervention. So in-session treatment. Now in that family crisis intervention article, they had a quite elaborate model of family crisis intervention focusing on creating a combined narrative that the teenager and the parents agreed upon, some cognitive behavioral therapy, a number of factors. Here, what I'm talking about is less complex or less ambitious, but still in-session treatment, active listening, empathy, helping the person clarify what happened when and how they feel about what happened when, what their reactions are, things like that you can help clarify in the session, and which sometimes can make a difference in the eventual outcome of the level of risk of the person. Then the third part of the emergency intervention is the disposition or plan. What happens next after this individual session? And what happens next depends on the eventual decision that you have to make, or whoever is doing the interview has to make, about whether this person is high risk, moderate risk, or low risk. Okay, the plan or the disposition follows from the level of risk. So we'll start with high risk. And high risk means that the individual needs containment or prevention, and there's really only three ways for an adult. There's only three ways, or a teenager for that matter, only three ways to provide this kind of containment or prevention. First is hospitalization, and that's, I guess, pretty straightforward, probably the most common. And of course, hospitalization can mean either voluntary or involuntary. With minors, that is, children and adults under 18, then the parent or guardian has the authority to sign them into the hospital, and it's still considered a voluntary, whether that child or adolescent is agreeing to it or wants to go in or not. Second is a residential program with one-to-one staffing, a high level of staffing, and this is sometimes available for teenagers who are in residential programs already, but it's unfortunately rarely available directly coming from the outside world. But a highly staffed residential program would be the second. And the third kind of containment is the continuous family watch, which is typically only appropriate for a teenager or a young adult. And in this case, it's important to assess the level of the family, whether they are taking the situation seriously, whether they're responsible and have some insight and some motivation here. But the idea would be to send the teenager or young adult home with their family. Typically we're talking parents who would agree to keep them under a continuous watch for typically 48 hours and then come back again for reassessment at that time with you again or with someone who has access to the records. So during that 48 hours, the parents or the family members are expected to keep eyes on the client almost all the time. Like, it's okay to let them go to the bathroom. You don't have to go into the bathroom with them. But you do have to be sure, for example, that they can't climb out the bathroom window and run away, that their bedroom window doesn't open out over the garage roof and that kind of thing, where the parents and family keep their eyes on the client pretty continuously throughout that time, and then again return in 48 hours. And I've seen some striking improvements in teenagers and young adults when they do that, and it's not exactly clear how that comes about. Is it simply that having the parents and the kid together sort of forces the issue and they're forced to talk, or is it that having the parents do that is a show of love and care that the young person doesn't really know is there or not? Or we can speculate a lot about just putting them together shakes up the system. We could speculate a lot about what's the mechanism of change here, and but it's important to keep in mind we're talking about only 48 hours or so. We would not ever ask a family or parents to keep guard or to do a continuous family watch for a week or for 10 days or anything like that. That's clearly what a hospital is for. But for 2 days or so, then the continuous family watch can often substitute and can often replace the need for hospitalization. I've had many situations where the young adult or the teenager and the parents come back in 2 days, and now the risk is moderate as opposed to high. And as I mentioned, something went on, something changed things, and now the risk is moderate, and the young adult does not need to go into hospital and can continue as an outpatient. Okay, now it's important to point out here in the second bullet point that just because an individual is high risk doesn't mean that they're definitely going to try to kill themselves or harm someone else for that matter. In fact, most people who are high risk are not going to carry out a suicide attempt in the next couple of weeks. One study estimated that between 2 and 5% of people that we would rate as high risk would actually make an attempt in the next 2 or 3 weeks. So if you think about this class, we have 25 people, so let's pretend that each one of us has one high-risk client. We all talk over the cases with one another. We all agree that this client and this client and this client, one for each of us, is high risk. And so we decide to do an experiment. And so with that high-risk client, we cancel the appointments, we step back, we don't do anything, we don't make ourselves available, we don't return their phone calls. What would happen? And the idea being that only a small minority of those 20 or 25 people would actually try to kill themselves, probably 1 or 2. The only issue is there's no way to know which are the 1 or 2 out of the 20 or 25 who would actually make that attempt. Okay, so this foreshadows what we're going to talk about a little bit later about the inevitable false positive rate, or their tendency to overestimate suicide risk among our clients. After all, suicide, fortunately, is very rare. Now, we also need to keep in mind that everybody who tries to kill themselves would not have been rated by high risk. Many would, but keep in mind that some people that we might rate as moderate risk or even low risk can go on to make a suicide attempt in the next few hours or the next few days. Partly because suicide risk is very fluid and changeable, partly because people might not tell us the honest truth to everything, or partly because we don't really understand what this is all about. But sometimes people that we think are low or moderate risk actually make serious attempts or do sometimes kill themselves. Now, I want to make a brief comment about the idea about rating people as high, moderate, or low, and why we use those words in that way. So I had an experience a while ago, probably 15 years ago. As you know, I'm in private practice, and at that time we had a different office than we do now. At that time we had an office that was shared among maybe 6 or 7 different people, mostly social workers, and we had a break room, and the break room had the coffee pot and the mailboxes and the fax machine and a sink, things like that. And so one day I went, between sessions, I went into the break room to get a cup of coffee, and I saw that someone had left a piece of paper on the fax machine. And of course, you all know that in a confidential situation like a psychotherapy practice, that if you found a piece of paper on a fax machine, that you should obviously not read it, but return it to the person that inadvertently left it there. But what can I say? I didn't do that. I read it. And in reading this fax, what I kind of was able to piece together and figure out was that the clinician, the social worker in our office, was seeing a client who was at some risk for suicide, and that client was also being seen in group therapy by a different therapist in a different office or a different clinic somewhere else in Chicago. And the 2 therapists, it became clear to me that the therapist in our office was the individual therapist, and the therapist across town somewhere was doing group therapy, that the 2 of them stayed in touch with each other by each time they had a visit with this client, they would write a progress note, and then they would fax the progress note to each other as a way to stay in touch, which is fine. Presumably they have permission to do that. It's fine, except that what I noted on this progress note that was being faxed was basically something like, the client is struggling with this issue and that issue and is having a really tough time and blah, 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 and he remains at high risk for suicide. I will see him again next week. Okay? Now, that's a problem, because using the word in that way, now I don't contest that the social worker in our office made the right judgment. That is, that the client could go home and come back next week. At least I think that was the right judgment. I mean, what do I know, really? But what I'm talking about is not whether that was the right judgment, but that was the wrong label to put on that judgment. If you call a client high risk, and then if unfortunately something does happen, like that client does attempt or complete suicide, and there is a lawsuit, the first thing the lawyers are going to notice is that you called that client high risk and then didn't do anything about it, right? In the legal world, high risk means you think they're going to try to kill themselves. So you should only use the term high risk when it is someone that's at the level where you think they need to be hospitalized, or on a one-to-one in a residential program, or on a continuous family watch. Okay, now how about moderate risk? Okay, if you rate someone, and by the way, the only way to make these ratings, you notice I haven't listed, certain risk factors on one hand or certain protective factors on the other hand. This is only something we can do with case examples, and we will do that, as the semester goes on. But what moderate risk then means is, remember that the danger, the mental health emergency, almost always arises in the context of a crisis. So moderate risk means we feel this person is safe enough to continue as an outpatient in crisis intervention with suicide precautions. So we already know what crisis intervention is. Suicide precautions would mean more frequent visits, would be frequent discussion of suicide risk. It would mean removing lethal means, especially guns and pills, from the person's home, which is a whole thing in of itself that we'll talk more about. That you would keep considering the possible need for hospitalization, that there would be some 24-hour availability set up, that you have an alliance with the family or the roommate, that you would consider medication or a change of medication, that you're constantly willing to reevaluate the treatment plan, that you're using a consultant, and that you would use the safety planning intervention, which is actually a specific formal intervention that we'll talk about a little bit later. Okay, this is what moderate risk is. And then finally, low risk is for someone that you would consider appropriate for routine outpatient treatment or regular outpatient crisis intervention. And this includes people who often say, or we say about them, that they have passive suicide ideation or passive death ideation. This is the person who says, no, I'm not thinking about killing myself, but it would be okay with me if I got hit by a bus. Or, no, I'm not talking about actually doing anything, but sometimes I wish I just wouldn't wake up in the morning. Okay, now traditionally those things were called passive, either suicide or death ideation, and were considered less risky, but now there's some evidence, or at least there's some experts believe, that the passive ideation, the I wish that I wouldn't wake up in the morning, is just as risky as the more active ideation, like, yes, I am thinking about suicide. Okay, so this is our overall outline for the emergency intervention. Again, the core being the risk assessment, and then the risk assessment yields a determination, a decision, a clinical judgment on your part that the client is either high risk, moderate risk, or low risk, and then the disposition flows from that. Okay? Okay, well, I'll see you next time.